Mucinous neoplasms of the appendix, I'm sure most of your guys' favorite subject. I don't know if you're anything like me, but when you have a pile to sign out cases-wise and you know one of them's going to be a mucinous neoplasm in the appendix, you kind of start to think, oh, geez. And it can be a lot of slides, and there's a lot of confusion here. And so I thought it'd be nice to spend, I'll take under an hour, and so plenty of time for comments, questions, and a lot of this is me, admitting to the fact that we don't all agree on a lot of these topics. The nomenclature is still very confusing, and so just trying. The biggest thing for me that you might take away from this is really just helping to start differentiating, benign mimics of neoplastic lesions from Lamans, Hammonds, and whatnot. Okay, so we'll go through a couple interesting cases. We'll talk about some of the current classification schemes, controversies in the nomenclature and staging. I've been at Weill Cornell most of my time. I also worked at Michigan for a year and worked at MSK then for about 3 months. And at each of those places, the way they treated these were very different. And so, again, kind of going back to some of the controversies. So I did train under Dr. Yantis, and so a lot of this is coming from basically her brain transferred down to mine. And then, again, we'll focus on those benign mimics. Okay, so to start out, this was a case that was given to us for consultation. This is a 66-year-old woman who had a history of appendicitis. She presented, she had some imaging done and had some appendiceal thickening that was a little worrisome. When we go back to her history, she was initially treated non-operatively for complicated appendicitis. About 6 months ago, she received IV antibiotics. She had a drain place. She ended up improving and decided not to undergo a routine interval appendectomy, but instead was followed just clinically. She ended up having some imaging that showed slight thickening of a portion of the appendix, about 1 centimeter, so minimally kind of enlarged, and you can see that area here. So given the concern for potential neoplasm, they submitted the entire appendix. Fortunately for this case, it was a small number of slides. I know, as you can imagine, these can get very, very lengthy cases if you're submitting the entire appendix. And so, fortunately for us, it was on the smaller side. And that pathology had taken a look at the case, was not really sure kind of what bucket to put this in, and so they sent it to us for consultation. And you can see here why this was, a little bit complicated to start to interpret. So they did submit the entire appendix, and we can see here what the issue is. So here's the normal lumen of the appendix, and we've got a perforation here full of acellular mucin.
Okay, I'll talk about autoimmune hepatitis. Autoimmune hepatitis is kind of a classic medical liver disease. It comes up in the differential a lot for both acute and chronic hepatitis patterns of injury, and those are the most common patterns of injury, so autoimmune hepatitis is often in the differential diagnosis. Just a little bit of clinical background on this disease. It's much more common in women, especially those with other autoimmune conditions like Hashimoto's thyroiditis. And of course, you have these positive serum autoantibodies. But the point to make about that is that these serum autoantibodies are very common in patients in normal individuals. So if you happen to have a female patient who has these positive antibodies, you can easily overdiagnose autoimmune hepatitis. That's why I really stress the value of the serum hypergammaglobulinemia. That is uncommon in both males and females. So the presence of a hypergammaglobulinemia really strengthens your impression of a true diagnosis of autoimmune hepatitis. So it's worth asking for this if your clinician doesn't order it, and to find this value if they have ordered it. If you're in a hospital where your liver biopsies are being ordered by hepatologists, they're probably going to have that value for you. But if you're dealing with a gastroenterologist or a family practice physician, or God forbid a surgeon ordering the liver biopsy, then you might have to recommend further clinical workup in order to establish a diagnosis. So can you have seronegative autoimmune hepatitis? And yes, about up to 10% of cases, I think that's a little high, but up to 10% of cases are seronegative for the usual antibodies. And what does that mean? Probably what it means is that it's just a low level of titer that's not detected by the testing, or that later on they will develop that antibody and it will be positive. But sometimes it's just a different antibody that's not routinely tested for. So there are additional antibodies beyond the ANA, anti-smooth muscle, and anti-KLM antibody tests that that our hepatologists normally order. Okay, so there's a clinical way of diagnosing autoimmune hepatitis, and it does have a histology component to it, a liver biopsy.
Okay, so we'll talk about synovial tumors for the next 45 minutes or so. We already talked about, we're going to talk a little bit about the embryology of the synovium, and we're going to talk about the most common tumors involving the synovium. And we already yesterday talked about the prosthetic debris reaction, infected prosthesis, and we talked about the metal-metal reactions you can see in prosthesis. Now, if you take sections of the, like fetopsies, then you can see in early development, you have this so-called interzonal mesenchyme, which are these very primitive mesenchymal cells that lie between the developing mobile cartilaginous skeletal elements. And these are the precursor of the synovium. These cells undergo apoptosis, many of them, and this interzonal mesenchyme becomes the synovium of the synovial line joints. When you look at the normal joints, they're lined by the synovium or synoviocytes, which in the sort of inactive form are frequently sort of flattened-looking cells. When the synoviocyte become a little more active, they have more of an epithelioid morphology, like you see here. And they're sitting on this underlying connective tissue that is composed of fibroblasts, blood vessels, scattered inflammatory cells. There's no basal lamina that separates the synoviocytes from the underlying soft mesenchymal tissue, and this is thought to facilitate the transport of material or nutrients back and forth from the synovial fluid. Now, there are certain stains that normal synovium stains for. They stains for clusterin, they stain for D240, and these are stains you can use in diagnosing some of these tumors that arise from synoviocytes. They can also be focally desmin positive, and there's also KISH for CSF1 that is available, and there's also immunohistochemical stains available that can also be helpful in identifying some of these synovial tumors. It's also important to remember that although synovial line joints is usually where we think about synovium, you can also get synovium in extra-articular location, lining bursa, tendon sheath, etc. So all these neoplasm that we talk about today can both arise within joint, and they can also arise in an extra-articular location. And this picture to the left is sort of a schematic image of the synovium, synoviocytes are on the top, and the lack of basement membrane from the underlying connective tissue. These are sort of the tumors of the synovium. You have the tenosynovial giant cell tumor, though.